Welcome back to Aussie Med Tutes. If you don't know me, my name's Francis. I'm a final year medical student at Sydney University in Australia. I'm in the final block of my paediatrics term, and that means next week I have exams, so I'm a bit limited in the time that I have to make videos. Because of this, I thought a great video would be to go through a practice test that I've just done, my thinking while doing questions, and give you a bit of an idea of what to expect on a med exam. If you haven't already, please be sure to like this video, subscribe so that you can see when I put new things on, leave a comment if there's something else that you want to see, or if you've got something to add to the information that I give today. So the first question is on food allergies in children. It's giving you a few options on eggs, nuts, fish, and asking which of these are likely to resolve as the child gets older. This is a very easy question. It's kind of just a rote learning, memorizing question. And there are a number of foods that can cause allergies, but some of them are known to resolve after the age of about 1. So there's a group of foods: eggs, milk from cows, milk protein from cows, soy and wheat, that can cause allergies when you're really young, but 85% of kids that have these allergies will grow out of them. So for this question, it's very easy for me to figure out the answer is going to be egg. Sorry, I just realized I had a fan on. The next question is on shock in children. It's asking what symptoms you would expect to be early or late. The question is worded as which of these is a late symptom in kids. The things that you might see in shock are the body not being capable of providing blood to everywhere it needs to go. So in hypovolemic shock, when you don't have enough blood volume, the body begins to feel cool at the extremities, the rate that your capillary refill slows down, your heart might start beating faster to try and cope with that. You might also see that the blood capillary refill. So the options for this question are tachycardia, and it's asking which of these would be a late symptom of shock in children. So children, it's important to know where they're similar and where they're different to adults, and one of the areas that they're different are how they will present with shock. In some ways it's the same, but when it comes to their blood pressure, hypotension is quite a late sign of shock in children. So this was an easy question to answer as well. The next question is on a child presenting to a GP for a somewhat routine procedure. It doesn't really matter what it is, but GP then listens to the heart and notices, hey, your second heart sound is split, which, happens with children, but he's noticed that it's fixed. And he's hearing that when they breathe in and when they breathe out, that fixed splitting doesn't change. For this question, it's important to understand a bit of the anatomy of the heart and how it works. With the heart, there are 2 heart sounds commonly accepted, S1, S2. If you've studied cardiology, this is pretty straightforward. If you haven't, sorry, but this video isn't on explaining cardiology. But as somebody doing this question, I'm thinking, for children, there's blood going to the lungs, which can sometimes delay part of that second heart sound called P2, and that can lead to splitting. That splitting occurs because when you're breathing in and out, the pressure in your body compared to the pressure in your lungs is changing. And so that second heart sound, basically P2, can happen a bit later. What can make that stick is if you've got extra blood flowing to the lungs. What happens that can cause that extra blood to flow to the lungs is the answer to this question. So before I tell you that, I should give you the options. What's causing this fixed splitting of the second heart sound? Is it a ventricular septal defect? Is it an atrial septal defect? Is it a stenosis in the aorta? Is it a stenosis in the pulmonary vasculature? The answer to this one isn't super clear, at least it wasn't when I first learned it, but it was for me by the time I got to this test, fortunately. And the answer is it's an atrial septal defect. Your left heart is a high pressure system. When you've got an atrial septal defect, blood is shunted from that side into the right side of the heart. That means that you've got more blood going into the right atrium, which then goes to the right ventricle, and hence more blood going out to the lungs. Having extra blood going to the lungs means that that second heart sound's P2 is delayed, meaning that the pulmonary valve closes a bit later. Next question is of an Aboriginal child, 6-year-old, that comes in with otitis media. This is an infection of the middle ear. The problem is that this is complicated. This child has discharge coming out. The question's asking, how would you manage this? So ordinarily, otitis media can sometimes be managed conservatively. You can wait and see how it goes with recovery, but there are some groups that are considered to be high risk. The high risk groups are those under 6 months of age, those that are under 2 with bilateral otitis media, those that have a perforation with discharge, and Aboriginal and Torres Strait Islanders. Additionally, some people with craniofacial abnormalities and people that are immunocompromised can also be considered high risk. So in this question, given that it's a high risk group, you obviously wouldn't manage it conservatively. So then the question asks you, did I just say asks? The question asks, would you give them IV antibiotics, oral antibiotics? Would you give them steroids? Or would you give them just a washout of the ear? How would you manage this? The answer to this question is to go with oral antibiotics, which are the method for treating acute otitis media with perforation and discharge. Reason being, it's in a high risk group, so you need to treat it. However, it's also important to understand that these infections are bacterial, so steroids aren't going to help. It's not the body being overworked. You've got to treat the bacterial infection. The next question is really just asking, hey, intussusception. That's a pathology where the gut kind of folds in on itself. What age group does this present in? So I could give you options. Is it most commonly going to present in the neonate? Is it most commonly going to present in those aged 1 to 2 years, 2 to 4 years, 4 to 6? This question, it's really just a rote learning question. However, it is still important to know this for certain conditions because there can be different pathologies that present similarly, but they can be differentiated by the populations they're more common in. For this question, intussusception is more common in people that are 1 month to 2 years old. Here's a good question because this is one that I got wrong when doing this test and I can explain why. But first, you can have a go. So the question is just asking about characteristics of murmurs in children. An important thing to know ahead of time, if you don't already know it, is that some murmurs in children are considered innocent. It's common for children to have murmurs of the heart, but there are certain characteristics that can tell you whether this is going to be a problem, such as a defect within the heart, or if it's just because they're young. The question asks you what characteristic suggests that this murmur might be benign or innocent. The options are the murmur that is pansystolic, a murmur that is diastolic, a murmur that is a short systolic, or a murmur that has a blowing quality. Now, when I was answering this question, I was thinking, I can remember my doctors when I was on the ward, when I was doing an exam, saying innocent murmurs often have a blowing quality. So I'm thinking when I answer this, oh yeah, blowing quality, easy, there you go. However, it's not the correct answer because some larger heart defects, so a large ventricular septal defect, isn't a very loud defect when you listen to the murmur, but it can have this blowing quality. So if I've already ruled out one of these possibilities for you, can you guess which of the other three it might be? The answer is short systolic. Ventricular septal defects are often pansystolic, meaning they go from S1 to S2. So obviously pansystolic is not going to be indicative of an innocent murmur. And then when you move to diastolic, those are never innocent. That is something that they're quite clear on when they're teaching us. Therefore, there's only one option left. It has to be short systolic. All right, I've got to get back to study, so I think I'm going to leave it there. Hopefully this is something that interests people though, seeing how to do a medical exam, how to think through some of the questions, important things to know about, and also maybe the difficulty to expect. I hope this was useful. If you've got other things that you want to see, make sure you let me know. I do have a lot of videos in mind and things that I'm going to be working on, but they're going to have to come out when I've got the time. Until next time, I'll see you then.